Welcome, everyone, and thank you for coming. I want to take 2 minutes and thank some people who were involved in supporting PACE in Durham Region from the beginning. Ajax Town Councillor Lisa Bauer and Regional Councillor Joanne Dyes sponsored a motion at Town Council that passed unanimously, calling for PACE expansion in the town after Burlington PACE proponent Councillor Paul Sharman made a presentation to Ajax Council. That motion was copied to the Minister of Health, our MPP, the Chair of the Region, the Durham Health and Social Services Committee, the Regional Housing Corporation, the Local Municipal Housing Corporation, all Durham lower tier municipalities, the President and CEO of Lakeridge Health, the Durham Ontario Health Team, Community Care Durham, and Durham Mental Health Services, and good for them for copying all those people. James Meloche, CEO of Community Care Durham, and our presenter tonight, stepped up with a comprehensive plan, one enthusiastically supported by Community Care Durham staff and board. Morgan Denby, Community Support Specialist at the region, advocated for PACE adoption at that level. Aaron Vallant, Director of Housing at the region, stepped up to offer space in regional buildings to help make this happen. Samantha Patterson, the Government Relations and Strategic Initiatives Coordinator at the town, was helpful in providing meeting space and offering her expertise. Lisa Kitchen, Director for the Durham Ontario Health Team, was supportive from the beginning. Cecily White, another Seniors for Social Action Ontario board member, also offered her support to the committee to get it expanded here. All of these people came together to help make this happen, and I'm personally very grateful to them. And now, it's my great pleasure to introduce to you James Meloche, whose leadership has been vital in this effort from the beginning. James has a doctorate in political science and government from the Catholic University of America in Washington, D.C. He's been a government policy advisor, a senior director of the Central East Local Health Integration Network, and a strong advocate for older adults throughout his career. Seniors for Social Action Ontario was so pleased that he accepted our invitation to do this presentation for us this evening. Please welcome James Meloche.
It's a real pleasure to be here. Before I get started, I see some familiar names on the guest list, and I want to give them a shout out because I think in many ways they have been mentors in my journey in specialized geriatrics or seniors care. So I see Anne-Marie Yakimovich is online. Anne-Marie has been a patient family advisor with back in the earliest days when we met in 2003, I think, or 2005, Anne. And then I also want to give a shout out to Dr. Jenny Ingram. I haven't spoken with you in a long time, Dr. Ingram, but I hope you're doing well and glad to see you on this call. I will go through my material today. I'm going to try and share my slides, so just bear with me while I pull this up. It should be ready to go. A little bit about myself. I will thank you, Harry. And Harry, I'll just give you a move forward if you don't mind. Great. So if we can just move forward, thanks.
There you go.
I have had the pleasure of being the CEO of Community Care Durham since 2019, and I'm seeing some of our past board members here, Keith Tournay, online. And it's so far, I would just tell you, it's a pleasure and an honor and a dream job to be part of this amazing organization. I've come through various areas of senior policy and planning in the Ministry of Health and Local Health Integration Networks. But as much as I love policy, what I really love is actually turning ideas into reality. And being at a place like Community Care Durham, I feel we're, with a great team, we're able to take these ideas and make them impactful. I've had a passion for the care for older adults and population health for my entire career. I don't have a background in medicine. I have a political philosophy degree. But like many of you, I feel compelled by a sense of duty to our fellow citizens and helping them improve their quality of their life as they define it. If you want to know a little bit about me, I'm a cyclist, I'm a hiker, I'm a photographer, and I love food and coffee. So those are that's my bio right there. Next slide. Just a bit of a disclaimer. I have nothing to gain here other than hoping to promote this idea with all of you with regards to spreading PACE in your communities and being an advocate for change. And as far as the information that we're providing, it is provided by the data I have essentially at Community Care Durham, Ontario Health Data, but none of it has been paid for, and nor am I reaping any benefits for this presentation. So if we can move to the next slide. I'm not seeing the slides change, so is it just me or?
Here it is.
There it is.
Okay, can we go to continue forward, please?
Sure.
Right, and we'll go one more. So what I'm hoping to achieve tonight, the purpose, one back, is if we can go one back, please.
There's some problems with these slides. One back. How's that?
No, you went forward. That's okay.
Go back, Harry.
There we are. We're good. We're good. I'm hoping to establish some key concepts and offer some potential solutions that may address the needs of patients, caregivers, clients, communities. I tend not to use the word patients in this circumstance, but we use the word clients or participants. Just so if you're, depending on your nomenclature, when I refer to clients, those are generally the people receiving services. And I want to conceptualize with you what I believe is a community-based primary healthcare solution, which we know as PACE. And particularly what I want to demonstrate is how this model might work alongside primary care innovations that are happening or health homes, and about how we might coordinate and tailor home and community care for adults who are long-term care eligible. So next slide, please. So I think it's important to rephrase the problem statement, but many of you have firsthand experience with this. What is amazing is that until you actually need the service or a loved one needs the service, you really don't know the disaster that home care is in. And it is in a very bad shape. Services for seniors or for any population that's considered frail is fragmented and lacks integration with other parts of the health system. And it leaves clients and their families to navigate a very complex and disjointed network of providers. On top of that, in some communities in Ontario, for example, in northern rural communities, many of the services that are required are not available, or they're often precariously available, given some of the financial and human resources, staffing issues, financial reasons. And what's also quite important, and I think this is actually fundamental, is that there's a total lack of integration between the health and wellness services, resulting in seeing individuals as transactions rather than people. And I will just stop there that, while we work on how to improve clinical outcomes for those with stroke or COPD or congestive heart failure, none of those factors, none of them, actually have any causal impact on a person losing their independence. The causal impacts tend to be cognitive, mental health, or they tend to be social, lack of caregivers or a lack of housing. Those are the drivers for people to lose their independence, not a clinical issue. Next slide. And I also want to start with this notion that, you're going to be hearing or can hear PACE is a US model, as I'll explain, that it can't be done in Ontario. And I'm often told this, PACE can never happen in Ontario. But why is that? Well, to be blunt, there's a lack of political will, both on the bureaucratic side as well as the provider side. The bureaucratic side, we still enjoy working in funded silos or organizations that are in silos. And we hold on to those silos because they're our safety net. Because that's our brand, because that's our name. But we work in a system that's completely broken into silos of services. The second thing is that there's inherent competition between not-for-profit providers and profit enterprises. And no one likes to talk about it, but it's absolutely real. And I'll explain this to you in a minute. On the community side, where I come from, there's also variation in capacity in the mission of community support services agencies to take on these type of goals because they're very familiar and comfortable with working with social enterprises or social activities, but the healthcare component, that's less their jam. And so they tend to be more resistant to do that. But the number one reason I would suggest to you is that there's a lack of coherent vision for aging well and aging in place in Ontario. There is no plan. And I've been around many plans before that always got
Look
derailed.
at my host computer and see
So-
Oh, they're coming in now.
Are we good?
the faces.
Okay. So what I will offer to you is that while Ontario doesn't have a single health system, we have multiple providers, hospitals, long-term care, community agencies. There is a single system, a single insurer. And because of that, I think we actually have all the tools and incentives to implement PACE-like models in Ontario. Let's move forward. Next slide.
Very next. Oh, there we go.
There we are. I'm going to give you a little bit of a story of our clients throughout the journey. So we put a human face on this. And I think this is true for many community organizations. But I'll just share with you the word of Liz, who's 95 and lives at home with her care partners. Liz is enrolled in our adult day program, assisted living services, and receives foot care from us. Her story is that if they have not received CCD services, they wouldn't feel supported, and mom wouldn't have the quality of life that she has today, with the socialization, the companionship, the friendships that she's made. In a world without organizations like ours or other community organizations, their life would be unpredictable. And this is the notion I'm talking about, of trying to navigate and weave together solutions across multiple providers. It's a real chore for clients and for their families. Next slide. So I'm going to go over some definitions here. And by the way, all the photos that you're seeing are actually our clients. They're my photos I've taken, but they're people who come into our program and they tell our story. So next slide, please. I thought it was important to situate the concept of PACE within the broader healthcare spectrum around the continuum of care from primary care to long-term care. And I know Trish and SOAO is really keen on NORCs, and as are we. But I wanted to just show you that when we talk about PACE, it's distinct from NORCs, but they're complementary. And I'll just outlay those in a moment. We believe fundamentally that the entry point into the system needs to be primary care, however that's defined in a community. NORCs are really focused on those activation or social connections that keep residents in place, living active and well lives, social and connected lives. Home care crosses a continuum of services from episodic to long stay for services provided at home. And what PACE does, it actually brings all the things below it together into a comprehensive whole. I'll move forward to the next slide, please.
Sorry, James, he was fixing my computer. He'll be right there.
Okay. So we're going to talk a little bit about NORCs because it's a really important topic. And I won't go into a lot of detail here because I know that Trish has done this before. So area there is wellness, social connection, activation, community supports. These are for seniors who might not be ready for long-term care or eligible for long-term care. They're just looking to age well in place in the communities. And what services can we be providing to them that helps them do that? So those are, next slide, please. They're really geographically based around certain communities, whether they be vertical or horizontal. And they're not retirement homes, nor are they assisted living facilities. They are people's homes. And the individuals, the community themselves, self-organize to attach or to create those resources that best suit their needs, whether it be exercise programs, food services, any social activities. This is really important because the sense of communities that NORCs bring are recreating what we've really lost in Ontario is that sense of community. My organization was started in 1977 by community members, social activists who came together and addressed some social issues around food security for a number of people in the population. those communities are very rare these days because people's families have, there's diaspora families. People are now moving into our area that aren't from our background. So we have different types of communities forming within us. So what we're trying to do with NORCs is recreate that sense of community, which we had back in 1977 when our organization was formed. I'll go to the next slide. Home and community care, and I will stop on this because this is really important. Next slide, please. You won't be able to see this slide very well, but just bear with me for a moment. This is a Government of Ontario Ministry of Health depiction of what home and community care services are. And there's, with the exception of the Indigenous services with a blue pie, I'm going to focus on the fuchsia pie and the purple pie, the fuchsia and purple pie being community support services and homemaking services. That's where a lot of organizations like mine live in. They'll do Meals on Wheels, transportation, adult day programs, foot care. They're funded in a different bucket. Homemaking and personal support services are usually found in supportive housing or assisted living programs, and we provide those too. Again, they're funded in a different bucket. So even within my organization, Community Care Durham, I'm receiving funding in the fuchsia bucket, and then I receive funding in the purple bucket and the green bucket. And I can't really mix them very well. The last corner, the orange slice, are professional services. And for the most part, those services are provided by service provider organizations who are on contract through Ontario Health at Home. They provide nursing services, occupational therapy, physiotherapy, social work. And generally speaking, you'll find that service provider organizations are not allowed to provide the fuchsia side. And the fuchsia side is not allowed to provide services in the orange side. And so we've created this pie that looks really nice, but it's not a pie. It's actually 5 different pieces that are fit together. So that is what home and community care services are. When you have an organization come into your home for nursing care, they won't provide, generally speaking, transportation or adult day programs. And in my area, we started a nursing program, which I'll talk a little bit later, which I was told by government, well, you're not supposed to do nursing. Well, I just sort of ignored that and said, but this is what our clients need. And I'm going to show you why they need nursing and these other programs like assisted living. We'll move to the next slide. The problem as I see it, and these are only my opinions, and other people can disagree with me. I think we can all agree that the home care population is not homogeneous, but the problem is the system treats them as homogeneous. Other than a few particular groups like palliative care or complex care for children. And what I think the problem we have in the home care system is that we assess people for their eligibility for a service, not necessarily on what their needs are. So if you're a home care provider or home care coordinator, you will meet with the family and the client, and you'll say, well, you're able to receive an hour of nursing or an hour of home care, but you might need social services, but that's not our problem because we don't provide that. So this is what you're eligible for. It's not based on needs. And the reason why this is important is because those eligibility tend to go to service provider organizations who are funded by the Ontario Health at Home Agency, whereas my organization, being a health service provider, is funded by Ontario Health. And we very rarely this is a typo here, we very rarely get referrals from SPOs or even Ontario Health at Home for our services. So this lack of integration between home and community services leaves families confused. And in the story I gave you earlier, our client was in a home and community care organization or receiving SPO, and they said, we're done with it because we have different people coming into our home all the time. We don't know if they're actually going to show up. And every 6 months or so, we have to reapply for the service. So this, again, leaves the clients and families confused. I get emails often as the CEO saying, what happened? What did you do to my mom? You've kicked her off the service. And I'll go and look up and I'll find that their mom was never a part of our service. They were getting service from somewhere else. And I have to politely explain to them how that works. if I have to explain it to them, and sometimes I have a difficulty doing that, you can imagine how difficult it is for clients and family members. And in this particular case, the family member was in Australia and the mother-in-law was in Pickering. So there's huge distance. So the other area I wanted to describe is that not every home care client needs holistic integrated care. Only the complex clients do. Some people just need it for 6 weeks or 6 visits and they're done. Others might need it for 6 years or their entire life. Next slide. This is just a slide for you to just see where these programs line up. Again, this is from the Office of the Auditor General of Ontario that looks at home care and assisted living for high-risk seniors, home care, and long-term care. And I'm in the middle, I'm in the bucket that's assisted living for high-risk seniors, and it's a fantastic program, and I wish we were doing more of it across Ontario. And I'll explain a little bit about that later today. Next slide. So here's something bold, and I have lived experience in this, and I know that Anne Marie is on the phone, and she might be able to kind of shake her head and agree with me on the background. But the truth of the matter is that the whole healthcare system has been co-opted by the problems facing the hospital system. I'm not suggesting that's illegitimate. I'm just suggesting that it's actually reoriented our priorities. So things like ED overcrowding or alternative level of care, people who are in hospital who no longer need to be in hospital, have forced us to redirect home care resources away from the community referrals to hospital referrals. And the perverse outcome of that is that people now think the only way they're going to get home care is to go to the hospital than to get the home care.
Right.
It's almost as if we wait for the disaster to happen and then we come in and rescue them. But oftentimes it's too late, and definitely it's more expensive. When I started working in the healthcare system back in 2003, 75% of the referrals to the home and community organization, then called the CCAC, came from the community. Today, it's about 75% come from the hospital. In the second year that I was leading the aging home strategy, we were working on community geriatric programs. The missive came down from the Ministry of Health. All the resources that were directed to community solutions need to go to hospitals and be put in hospitals. We're constantly reacting to the problems of hospitals, which lead to the most expensive care and prevent us from investing in those preventative solutions. However, even in the last year or two, we're learning something about these hospital to home programs where we're taking people home out of hospital, and we're doing this now as well. And I want to share with you a few highlights that are salient for this conversation. Next slide, please. What I ask you to consider this as caregivers and as clients. A large number of people, 600 people a day, are discharged from hospital to home care. But I know this sounds successful, but it says 92% of nursing adult patients receive their first service within 5 days. Can you imagine being at the breaking point where you have to bring your mother or father or your husband or your son or daughter to a hospital because you've just snapped and you're told, we'll get to you in 5 days? Or 80% of the population is looking for personal support services gets care within the first 5 days. At Community Care Durham, we started a hospital to home program with Lake Ridge Health and the emergency department. We provide care the very same day. What's also distressing to me is that while there's patients waiting in law hospital to get to home waiting for home care, over 355 visits are missed of care a day. That means, and I understand the numbers, around 30% of all home care visits never get filled and the patient or the client is left waiting at home. No wonder why caregivers are in distress, and no wonder why caregivers are saying, I listened to you last time when I brought my mom home, but I'm not listening to you again because it didn't happen the way you committed it to happen. And this is a very real but sad story. What these hospital programs also told, next slide, please, is that the home health service providers tend to do a better job than service provider organizations. And the better job is related to a number of things. they reduce the amount of time a person waits to get their service, and they connect those programs up to other social and community supports that are absolutely vital: transportation, food security, socialization, day programs. And what they also found is that bundled models, where they had flexibility to move dollars around that pie that I showed you, were much more responsive to meeting client need. So, and by the way, the costs were about the same. So giving the care that people want didn't cost more. It just required us to think more innovatively. Next slide. So I think I'm going to talk about PACE. I set up the table here. And what is PACE? Because the next slide, please. The reason why I set the table is that PACE is about comprehensive primary healthcare coordination across health and social supports. Next slide, please. It is not supportive housing. It is not home care. It is not primary care. It is a health home. It is community-based primary health care, where primary care is defined as that person who provides continuous, regular interaction with the patient or client or the participant. And that could be a social worker. It could be a PSW. It could be a community nurse. It may not necessarily be a physician. It is also integrating health and social services. And so I've been around programs in the province where I've heard people talk about the great things that assisted living does or supportive housing does, but it's not PACE. It's just a fantastic program. PACE goes beyond just providing the housing and supports in the housing. There are currently 178 PACE programs in the United States, serving just under 80,000 clients, but the program is somewhat stalled. Can't tell you why, but there are many more Americans who are eligible for the program. But we continue to study it and we continue to flock to it as the nirvana of where we want to go with elder care in the community. Next slide. Just so you're aware, the program for the all-inclusive care of the elderly is, and this is absolutely essential, it is a managed care program with capitated funding, which means when a patient or a client is enrolled in the PACE program, there's a certain amount of money that is attached to the PACE organization. It's not, here's funding for home care, here's funding for primary care, here's funding for drug supports, and here's a bundle of dollars. And here's whatever that client needs to stay at home and live in the community, you spend wisely. When I've been in patient rounds in the PACE program, I took a team down there many years ago to Buffalo. There was a client who was suffering from her lack of mobility, was suffering from some pressure ulcers. The nurse in the room, the occupational therapist, says, this woman needs a new bed. They had a bed to that woman within 24 hours. In Ontario, that would take 2 weeks. The other thing that's really important is that is offered in traditional areas. So not just home care, but they can receive care in various settings. So wherever they decide to call home. Next slide. And the bundles of PACE program includes the following: home care, primary care and specialty medical care, adult day programming, physical or occupational therapy, drug services, social services, dental, hearing, transportation, and if necessary, short-term overnight stay in a PACE program, like a convalescent care program. What I want to highlight in the next slide is how important it is. You can have all these services together, but what is that there is no person in the PACE organization who's defined as the care coordinator. The team does the care coordination. And so through technology now, they round on those patients to say, what has changed of our client, our participant, that we need to be responsive to? So it's highly interdisciplinary, and the team works together as you would expect them to work together. Next slide. And finally, and I'm a huge advocate for adult day programs. I know it's not for everyone, but I can tell you that those who come to our program highly enjoy it, and the caregivers do too. The PACE program is centered out of the adult day services. And in that program, participants, as they're called in PACE, will come into the center And not only would they receive social and cognitive stimulation, but they'll also see the nurse or the dietitian. They'll receive rehab services. They'll get transportation services. And most importantly here is that the caregivers get respite care for, in our instance, from 8 o'clock or 8:30 or 9 o'clock to 3 in the afternoon. So they can go look after their own health and well-being. Next slide. So how has PACE performed? I think it's important to note here that almost half of PACE participants have a diagnosis of dementia. So we're not talking about clients who are just easygoing and to have light care needs. These are relatively at-risk or frail clients. What we have seen is that while they have pretty similar rates of hospital admission, hospital visits, they don't spend as long in the hospital, and they definitely don't return back. Most importantly, the quality of life that's been reported by the clients or participants and the caregivers is much, much higher. And overall, the spending is a little lower, or as you would expect for any other solution. So we're making people happier. They're feeling they're living the life that they chose to live. And it's, again, not costing us more. In fact, it's costing us less. Next slide. So I want to tell you a little bit about Community Care Durham as I kind of set the context for this. Next slide, please. This is our mission. Our mission is very simple: to support people and strengthen community. And we do this with our staff and our volunteers. But ultimately, our vision is that we create and support communities where people are able to maximize their independence and thrive wherever they live. We are all about helping people live the life they choose in the way that they've determined to live, with the goals that they have chosen for themselves. Next slide. We're almost 50 years old. We've grown from grassroots organizations across Durham region to now we're just about approaching $20 million as our annual budget. We have 340 staff, just under 900 volunteers, and we serve almost 10,000 residents across Durham region, from across the ages of 16 to 106. And at our last count, I believe we have about 12 residents or members of our program who are centenarians. We look at addressing the entire needs of our client group, from their mental well-being to their physical well-being and to their social well-being. Next slide. So why are we thinking about PACE? Well, we feel, for a number of reasons why we're adopting it, because we believe in it, is that we are a provider of a multitude of solutions that are very common to a PACE program. And as I said earlier, without, to our own kind of admission to you, we've been for many years, we worked in our own silos. In Community Care Durham, we had the silo of transportation, we had the silo of meals, we had the silo of adult day programs. And over the time I've been there, we've been trying to break down those silos so that we see our clients more holistically as a client of our organization, not a client of one of our programs. We've also been pushing our envelopes that in some areas that we're told we shouldn't be doing or other agencies don't do. So 2 years ago, we started a community nursing program. And why we started that is while we serve about 300 people every single day for their personal support needs in home, we were the first persons to see things like UTI infections manifesting, wounds not healing properly, cognitive issues that were not being addressed. And every time we made a referral to another agency, it was a matter of weeks, not days, before that individual received service. And many, many times that person had already lost their independence and was in the hospital. We wanted to support our PSWs and support our clients by bringing community nursing into our program. For the last 3 months, we've been providing hospital to home services for Lake Ridge Health, Oshawa, by situating our staff in the emergency department so we can settle those people home with our PSWs and have a nursing visit that same day. And we put them on a 4-week plan to develop a more sustainable care plan for them. And while not essentially something you all want to hear about, we've adopted business practices that really help us to scale efficiency, and using technology where now our entire team can see that client. We have really broken down the silos of our organization. But this last point is really important because you have to have a team that believes in PACE. And I remember showing a video to all of our supervisors and my managers and my senior management team of the OnLock system, which is based in San Francisco, as the grandfather, grandmother of all PACE programs. And it came from the perspective of the providers, the nurses and the PSWs and the physician, about what it was like to work in PACE. And I turned to my team and I said, do you think we can do this? And they all said, absolutely. We're doing it now, but we can take it to the next notch. And my board of directors last week gave me an endorsement to move this forward as quickly and as fastly as possible, because they believe, and I hope you believe, this is what we need in Ontario. Next slide. Just to give you a sense of our day programs, our day programs now have a waiting list of over 150 people. And most of our programs include all the ages you can imagine. But last year we provided almost 14,000 days. That's 14,000 days of caregivers getting a break. And that's 14,000 days of individuals getting the stimulation that they need. And while I can tell you about how many clients we have, I want to share with you our own personal story. I was meeting with the Rotary Club about a year ago, and I was talking about our day program. And one of the women came up to me afterwards and said, my husband was a part of your day program, and he absolutely loved it. He felt he was going to work every day. And he would come home from the day program talking about the ladies that he worked with. And that changed their dynamic at the kitchen table in the evening. And I fundamentally believe that the day programs not just help that individual, that caregiver, when they're they've got their break from 9 to 3, but it changes the dynamic for the rest of the day to be a more proactive, more joyful relationship. So next slide. And I think the social interaction is absolutely huge. I haven't talked about loneliness and isolation here, but I will tell you that for this population, isolation is the biggest driver, without any question, towards a person losing their independence, because they give up hope. And when you don't have hope, you don't self-care, you don't seek help, and you tend to decline. And we see this now, where isolation is a bigger threat to a person's health and well-being than smoking and alcohol consumption. Next slide, please. Just a little bit about our assisted living services very quickly. I won't go over it. We provide 24/7 support, 365 days of the year, both on a scheduled and unscheduled basis, to about 350 clients now at Community Care Durham. And it's personal support services and homemaking and now nursing. Next slide. That's in this. We'll make sure you have the deck. This is what is included in the ALS. It's the homemaking, it's the wellness checks. It's also care coordination. So our team, our clients have access to a care coordinator that helps them link up issues around food security, around social supports, around rental supplements. So we're there to help them throughout their entire journey. But I think it's in 2 slides from now. I want to share with you something really important. It's kind of a funny looking graph. If you can move forward, please. You're probably wondering what this is. Across the X quadrant, you'll see the age group of our population. We start at around 45 and we go beyond 100. And on the y-axis, you'll see the hours of per service day. So what's unique about this program is that we have clients that sometimes receive an hour a day, but that hour a day can be 4 times 15 minutes. We're helping them get out of bed. We're helping them mobilize. We're preparing a meal. We're not there for just an hour. We're there because the model works is on a 5-kilometer basis. We can be in the home within 30 minutes at any given time. And you'll see here that some of our clients flex up to 5 or 6 hours a day. You'll see the high dots. We never have to go back to home and community or to our funder and say, can we increase the hours of care? We increase the hours of care. We work within our budget to meet the needs of our clients, and we're not looking to get more approvals. In the current home care environment, if a person needs more care, they have to go back to their client, their care coordinator, get a home assessment, and then get a referral for the additional hours of care. That process can take weeks. We focus on the person, not the budget, and we still come within budget. There's a little graph there. I think this is just, I know it doesn't look like person-centered care, but if you look behind the data, It's about person-centered care.
Yeah.
Next slide. So what is our vision? Next slide, please. Think of it if you go and look at your cupboard, your pantry. And I bet you if you open up your fridge, you'd have all the ingredients you needed to make dinner, but you didn't have a recipe. You've got all the things to make cake, but you didn't make cake. Flour sitting on a counter, sugar sitting on a counter, an egg in the fridge is not cake. It's cake waiting to be made. And what we feel is we actually have all the ingredients to make the cake. The next slide is, in fact, the vision, where the client at the center of the program defines for us what their life goals are. And we coordinate for them assisted living, home care through community nursing. They're aligned with a community pharmacy, providing them falls, exercise, and occupational therapy services through group and individual programs, access to day programs, transportation to the day programs and all their medical appointments, their food services, and their mental well-being, whether that be peer-to-peer or having social workers on staff. We are out with the only area we are not filling that round now is in the occupational therapist, and we're just hiring our first social worker. The idea here is that this is the solution. It is not eight or nine different programs. People will be enrolled into a program that's tailored based on their goals that brings all of those services and wraps around them. And I'm happy to tell you that we have clients a part of our care team, and they're helping us shape where we're taking this. Next slide. Our future vision, and I'm so excited to see this happening. And I met with another organization on Tuesday called the Circle of Care, and I was so pleased to hear that they share similar visions as us. We purchased our building in Whitby with no additional government funding, with a vision of creating a home away from home environment that's centered on the PACE model. So our future ADP will bring together in the same center nursing support, personal care, caregiver support, mental health and wellness. And when I mean personal care, I mean shower facilities, a laundry service, and a hair salon and foot care. There will be some people who have difficulty with maintaining their laundry. They can bring it into our program and leave with clean laundry. An individual can come and have their hair done with us when they're in our day program, because as we all know, for many people, that matters. And if it doesn't matter, it's a lot of work to get out of the home to do the hair appointment. So our goal, we started this, is to open up this program in fall of 2026. We're just through the process of now securing a firm we received a $2.5 million federal grant to build this space. Our goal is to bring this across Durham, and we wanted to bring it to every community. We just thought we have to prove it to everyone else that this can be done, and we're going to do that. Next slide. We'll be focusing on a number of targeted communities in the region. And if you're thinking about this yourself, I would ask that you go and look at your own communities and say, where within a radius of 5 to 10 kilometers would you find a number of seniors with lower income households or seniors who are living alone? Because the isolation component is incredibly important. The PACE model is not centered off a building. It's not centered off a retirement home. It's not centered off a supportive housing program. It's around a community or a neighborhood. So people can be living in an apartment building, and they can be living in their individual home, or they could be living with their son and daughter, and as long as they're within that geographic radius. So I'd ask you kind of identify those communities within your own area where you might see a high proportion of seniors with lower income or those with seniors living alone. Next slide. I'm just mindful of my time. I think we've got a plan of how to move this forward, and we'll be pitching this. We're going to start actually right away with initiating a project for 15 clients. Our board has given us an approval to go ahead and do that. We've also developed a business case that shows how we can break down the funding out of their silos into a comprehensive package. And we're looking to bring research into our work so we can demonstrate that ROI for the taxpayer. I feel like we're still having to prove, which is amazing to me. No one's actually having to prove the ROI on a long-term care home. No one has to prove the ROI on an emergency department. But for some reason, we have to keep proving the ROI what we do in the community. Next slide, please. And what's really important here is that we've been working with our Durham OHT and our primary care leaders to link up the emerging conversation that Dr. Philpott will be having around health homes or health hubs with primary care neighborhoods, linking this model so that when we create these neighborhoods of PACE, they're aligned to primary care neighborhoods. So that right now, when people come into our program, we will actually be able to communicate and leverage their family physician through technology or bringing them through our community nursing programs to create open communication between the primary care provider or team and the community team. This is much more than just putting a care coordinator in a primary care office. This is about interdisciplinary practice. And we've been testing some technology where we're using phones to show wounds or to deal with medications where we're addressing issues on the spot. And finally, I want to suggest to you that I think every health home needs to have care pathways for at-risk populations. And I would personally suggest to you that we start to really think about a community-based focus, because we have to look at the assets within each one of those communities. And I can further suggest to you that family physicians are often troubled to dealing with the psychosocial needs of their patients because they don't have the tools to do that. And these types of programs can help them alleviate the stress they feel as primary care providers to address problems they're not well situated to address. So in our instance here in Durham, with the great champion that we have in primary care, whenever we come across a client who's unattached, they will attach our patient or our client for us. So none of our clients at CCD are unattached to primary care because we're providing a win-win scenario for the local physicians. Next slide. And we think this is scalable. I don't think this is rocket science. I think you just have to find the people with the programs and the willingness to do this together. And we're hoping to start with 50 clients in Ajax and Whitby and scaling across Durham. And I believe it's very scalable across Ontario. And I'm leading a conversation with others in the province to see how they want to build and grow PACE. Next slide. So here's the kicker. Well, how much does it cost? It's $95 a day, compared to twice the amount for a resident day in long-term care, which, by the way, is an outdated number because we've increased the nursing hours of support in long-term care, so it's much higher, and it doesn't count the capital cost. In that $95 a day, we provide enhanced home care support, fully subsidized adult day program, so there's no copay, fully subsidized transportation to the ADP clients and their medical appointment, and a $4,000 annual social prescribing budget to address any issues that the health system isn't well situated to fix, including capital equipment or home renovations, drug costs, extra food supports, or transportation services. So even with all of those, without a single copay of a client, with full care in the home and the community, with a social prescribing budget, it's still half the cost of long-term care. Next slide. So this is our mission. This is something we fully believe in. And the more I talk to people across this province, the more Trish introduces me to people, I realize that there are more and more people out there who want to see this happen. And so how do you do that? I think what I've learned in having spent my time in the bureaucracy is that the bureaucracy won't do it. It is a political movement. And you need to engage your local champions because older Ontarians want change. I will tell you very bluntly, if it wasn't for Joanne at Ajax Council and Trish, because I've been sitting on this for a long, long time. I mean, Anne-Marie will tell you that when we started the GAIN program back in the 2000s, I was already thinking PACE. But it took those people like Angela and Trish to really put the fire under my tuchus and get this thing growing again. And I'm so glad they did. And I owe the debt of gratitude to them. I think the other important is to link the solution back to primary care, because primary healthcare includes what happens in the community and includes what happens in the home. I think we need to collaborate with municipal governments. And I know we have our partners from Durham region here, where we need to really be focusing on our collective assets around solutions of NORCs or PACE. And that we need to be taking a population health approach, which I think is well situated to what communities or regional governments do. And I know this may be a bit controversial, but start with dedicated partners. I know collaboration is a wonderful word, but collaboration works only if it works. What I found in many cases, it just requires people to lead. The definition of a leader is that they go first. They set the way and they get their hands slapped and they get burned, but they led. And what I find sometimes in our current system is that collaboration essentially waters down our aspirations because we're just trying to make everyone happy. And so I would suggest you collaborate, but don't be bogged down. Move forward, because we don't have a lot of time. Frankly, we just don't have a lot of time. We can't bring everyone to the party. We have to get the party started. Next slide. So I just want to thank you. I want to thank the council and all of you for joining with me tonight. I'm happy to take your questions. But most of all, I want to thank those people who have been along my side, as I mentioned at the beginning of this presentation, who have just been teaching me about care for older adults, and as well as the people of my staff who have joined with me today, because I work with a group of people who are absolutely committed to making the best of what we do mean something for our residents and for our community. So I thank all of you, and I'd be happy, back to you, Trish, to take any questions.
That's great, James. Thank you so much. This has been a really, really good, informative presentation. I think everybody will agree. And I just want to say, you're absolutely right about the collaboration piece, because we know that there are areas of Ontario where people are so concerned with process, and they're so concerned with nitpicking that things are not moving forward. And what's really needed is leadership. And I've just been so grateful that you and I have been able to work together, that Joanne and Lisa immediately got on the bandwagon. The region, Aaron and Morgan have been terrific. I mean, that really, really helps, is when everybody recognizes that this is important, and we can help a lot of people this way. And we've all worked together really well. And I think as long as that happens, that's great. But you know what? Sometimes leadership involves having to actually kick some butt, and tell people, "Look, I'm sorry, but you're not going to take it off track. We're going ahead with this." And I think a lot of people these days, James, are afraid of doing that. So thank you for your leadership. And, I'm happy to continue supporting and kicking butt if I have to get things moving forward, because this is so important for people. So thank you. I want to apologize to everybody for the video problem at the beginning. It appears to have been Zoom. If you want to turn on your videos now, you probably can, but I know earlier on you couldn't turn on your videos. So, okay, if people have questions, yes, you can. James, we're going to give the slides to people, are we?
Yeah, absolutely, for sure.
Okay, all right. Glenn, you've got the first question.
So what's next? What are we being asked to do, or is this only an information session?
Well, I think what I'd be asking, Glenn, and by the way, happy to share your slides, is bring this back to your community and say, who's willing to be championing this type of program here? What ingredients do we require? And I've shared with you the ingredients. And can we bring partners together? I will tell you that my goal now, Glenn, is to find other champions across the province who also want to see this happen. So if you feel that or I might become aware, or you become aware of how to advocate for this with your local MPP, or your local regional council, and you see local partners, let's start to come together. And whether that's through Trish or others, we need to start building a coalition of individuals who are saying, no, we're going to bring PACE to Ontario. Because if it's just me going alone, I will probably fail. And well, we might not fail, it just might not spread. So Glenn, I hope that answers your question. I just hope that the information is helpful to you so you can have your own local conversations.
It is.
Yeah.
It's just that if I'm going to go talk with my MPP, who's the Ontario finance minister, I would need to take with me a body of information to present him and his staff. Just an oral presentation won't be sufficient.
The good thing, Glenn, is I'm taking that to the MPP, the Minister of Finance, myself, because he's also my MPP.
Okay.
And I'm meeting with the Durham caucus in the next couple of weeks. And so far they've been really supportive of what we're suggesting. So Glenn, I hope I've actually helped you in your Pickering Uxbridge neighborhood, and we might be able to do that together.
There you go,
Okay,
Glenn. Aren't you glad you came?
I am. I am.
I know. And Pickering actually, Pickering Council, I think needs to pick this up because Ajax Council has been fantastic in pushing this forward. And so, talk to Kevin Ash, talk to your local councilors and just say, look, we need to get on board here. We need to expand pace throughout Durham region, and that means Pickering as well. So.
Yeah, I'm glad to do that, but I need a body of information to take with me.
Yeah, well, James, you can take all of the information here. You're going to have the slides. And James, as he said, is going to be speaking with Peter Bethlehem Falvey as well. So that will be helpful.
I will, Glenn, you've got my contact information at the end of the slides. We have a 2-pager that describes everything I just said in 2 pages.
There we go. That's what I want.
Okay, and I'd be happy to
Okay,
give that to you.
there you
Okay.
go.
Thank you.
See how helpful he is? Danielle, you had your hand up.
Yeah, actually, I
Um,
wouldn't mind that 2-pager myself. I'm with the
I'm
Toronto.
actually talking to Danielle Turpin first, and then
Oh, sorry.
I don't know who's next. I'll
No,
have
that's fine. And I know
Okay.
it's a great name. Happy to share it with you. Yeah. So hi, James. I'm so glad I was able to participate in this. I'm actually in the beginning stages here in Peterborough on trying to implement a PACE model kind of wellness hub like you were talking about. We've already had conversations with Councillor Paul Sharman. He's come down to one of the first meetings that we've had. And when you talked about getting bogged down in bureaucracy, I think that's exactly where we're at right now. So my question to you is, who did you first initially get at the table? Who were those key voices and key players to kind of help get this going?
Well, Trish brought me to the table, to be honest.
Okay, well, she's doing the same thing with me too. So Trish, yeah.
You know what?
Uh,
Honestly, it started with, as I said at the beginning, it started with Joanne Dyes and Lisa Bauer, who were fantastic. They talked with Ajax staff about drafting a motion from Ajax Council. And then they invited Councillor Paul Sharman on my recommendation to speak to Ajax Council. He did via Zoom, did a great presentation, got everybody excited. And then the motion passed unanimously and was copied to everybody, to half the world. Thank goodness Joanne did that. But it was copied to the Ontario Health Team, to the hospital, to the region. And then by the time we were ready to get going, where we called the first meeting, and then James stepped right up, which was great. The Durham Ontario Health Team was there at the table, and so was the region. And so the key players were at the table. We went with the key players, Danielle. I think
Yeah.
where you might be getting bogged down in Peterborough is you've got too many players and not the key players. So you might want to,
Yeah.
yeah,
No, I
you
agree.
might want to get the key players who can move it forward, get them to the table,
Yeah.
and then see what you can get going. And if you have a nonprofit community support agency up there to partner with, that'll be really important. I
Yeah.
think.
Can I possibly get that? Maybe you can share that 2-pager with
I'm
with
going to ask James for that.
I was
So,
just going to say it with Trish maybe, and yeah.
yeah, we'll send it out to everybody.
Okay,
So
thank
I
you.
just want
Is
to,
that okay, James?
if I could just say one thing to Danielle.
Mhm.
Why wait for leaders?
You are
Yeah.
one.
We're
Yeah.
all leaders, right? You all signed up today. You all have access to key people. We're all leaders. And I would just suggest that what I first did internally was make sure I had the support of my team, because I didn't want to be a lone wolf.
Yeah.
And then the next day was get the support of my board, because I wanted to make sure we were doing something that was strategically aligned. It gives me as a CEO of an organization to operate in full confidence that my vision matches the vision of my team and my board. It also gives me the sense that I can stand behind the organization and say, we're going to redirect our resources to make this happen. Not every community or organization has that. I'm lucky to have that with the great team I have. But I would suggest that all of us are leaders. PACE might look a bit different in Peterborough. It might look a little bit different in, Tecumseh. However, the key components need to be there, the social and wellness and the health components. And I would suggest the day program is an essential element of that because it ties it all together. If it's just one or two of them, they're great programs. I don't mean to dismiss supportive housing. I don't mean to dismiss home care. I don't just mean to dismiss adult day programs. But PACE brings all of that together for a population that needs the support in weaving that comprehensive system, breaking down the silos, and allowing them to choose what matters to them.
Thank you. Yeah.
Daniela, I know you have your hand up, but did I cut somebody else off earlier? Do we have two Danielles or?
It was Daniela, I think, is the
Daniela. Okay,
Yeah.
Daniela, if you have a
Hi,
question, go ahead and then,
yeah,
yeah.
thank you, thank you. I'm so excited about this because the senior issue. I'm with the Toronto Alliance to End Homelessness, and I'm thinking, it's an umbrella organization of most of the social services agencies in Toronto, and we have an awesome mayor, right? And we really need to talk about. I'm so glad that we're having this conversation because this is what's needed. I'm a senior myself, and I would like to see this happen in our city. We have a really awesome mayor. I also think this is worth a presentation at the National Alliance to End Homelessness. And I would like to bring it to my steering committee. Um, Actually, I'll phone the CEO and just ask if there's time on the agenda to actually maybe play the video that you're going to share with me. I'll at least a two-pager. If I could get that, I will forward that and just start a discussion. I think, like the senior population is, I mean, we don't have enough senior homes, period. Right? I mean, I had said to them a couple of years ago at the steering committee, we need to be proactive. Or we're going to have a huge amount of seniors in homelessness,
Yeah,
and that's going to happen, right?
we don't, Danielle, we don't want people going into long-term care because it's not a good place.
Right.
So we want them in the community. And I think that's where James and his staff and board are so important. And that's why PACE is so important because in a lot of areas, PACE would work very well in community housing, seniors buildings, for low-income people. I mean, to keep them at home instead of forcing them into the hospitals, forcing them into long-term care. So James, did you have a comment?
Yeah, and I would just say, maybe I've been thinking about this over the last couple of days. Many of us who worked in the social services side tend to feel ourselves as being, well, we're the social services side, and we want the healthcare system to recognize how important social services are. The truth is, we've always known how important social services are. We've always known that social determinants of health are the biggest driver to a person's hospitalization or emergency department room. We've always known that, but it's almost like we just talk about it. So the healthcare system does the healthcare system part, and does the clinical piece really well, but they really suck, pardon the expression, at the social side. And when I've been in my organization, when I first joined there, and Keith is a member of my board, we were almost like, well, we don't do clinical. We're the social people. It was by bringing the healthcare component into the ranks of my social team, by bringing the nurses onto the program to show the benefits, that I broke down the silos of the social and the health system because we're actually working together. As of today, we started with one community nurse. We're now down to 6. And we've just taken over the dialysis program, supporting patients doing home peritoneal dialysis for the hospital, because we're just there to help teach. So what I thought, if the healthcare system isn't inviting you in, then you invite the healthcare system in.
Or break down the door.
Right.
Because sometimes that's what you have to do, I just want to say to everybody, we will get the 2-pager and the slides out to you. And the recording will be on the Seniors for Social Action Ontario YouTube channel within the next 2 days. Okay, just so that you all have access to it. And are there other questions people would like to ask, James? Either in the chat or if you want to put your hand up. The way you put your hand up is you go to React at the bottom of your screen, and it says raise hand. So if you click on that, you can raise your hand and I'll see it. I think, James, this is
There's a question by Lauren in the chat.
okay.
If you were approaching this endeavor as an OHT as opposed to being CCD, is there anything you would approach differently in terms of a starting point? Actually, I think we've been working with our OHT, and it's about aligning our agendas. And right now, where the OHTs will be absolutely focused in on is primary care. And you'll hear from Dr. Philpott, I think she started her job on Monday, talking about medical neighborhoods. She uses the analogy of school boards, where people living in geographic areas are aligned to a primary care practice. And this is what you'll see in the Frontenac Leamington Addington health home that they've established there, where it's an interdisciplinary team of doctors working in a team-based environment. When I met with Dr. Philpott in the few minutes I had with her, and I gave her the 2-pager, was saying, so this is a community model that works alongside a primary care model. They work hand in hand together. And so I would suggest through your OHT is attach this by going to the Canadian Institute for Healthcare Research. There's a definition called comprehensive community-based primary health care. And it defines what PACE is. And I would suggest if you were to go to your OHT, talk about primary health care and attach that to the primary care agenda. Because primary health care includes social supports. It includes public health. It includes all those things that we do in the social services. So to me, that is the linchpin for you with your OHT. And of course, yes, talk about ALC diversion and talk about ED diversion. But at the end of the day, this is about keeping people at home. So when people do need long-term care, and I know we may have differences of opinion on this, but there's some people they need the 24/7 support, then that's an option to them. But right now we're failing people much too sooner than they need to be. I'll give you a story. I met with one of our, I don't know if I will tell you, if you talk to people who are living at home and doing the everyday fight to maintain their independence, the specter of losing that independence weighs over them heavy. And it wears on their mental wellness. It wears on their sense of joy and their sense of well-being. And I think we need to give them an alternative. We need to show them there's an alternative path for them other than long-term care.
And if I can say, the way I sold it to Lisa at our Ontario Health team, I sold it to her as part of home care modernization. And I know that Ontario Health, and speaking with their CEO, I think he sees it as part of home care modernization to have PACE programs, because it's a different, more efficient way of delivering in-home supports to people as well. So that might be a vehicle as well for you. I see Julie and B. Scott and Denise have their hands up. So Julie, you're on. What's your question?
Hi, I'm calling from downtown Toronto. I've been on the Seniors Advisory Committee for the Nork Innovation Center's program run by the University Health Network. And I'm thinking I would like to send all your materials onto that group, but maybe you're already in partnership with them. At our advisory committee meeting today, we were talking very much about the gap between social services and medical services, and the sorts of unmet needs where if you have a medical emergency, you're pretty well taken care of. But at the level before you need a medical emergency, there's so little support for people. And that was very much the topic today, and discussing how NIC can extend its program to fill some of those gaps. So I just wondering, shall I send all your stuff forward to them, or are you still already talking to them, and do you see them as a partner?
I absolutely see them as a partner. I had a chance to be at a conference with them in Calgary about a month ago and got more familiar with their work, and then have now since followed up with them on their research work to see how we might kind of tie things together. I believe that the NORC movement is a broader movement that needs to be pursued irrespective of PACE. This is about maintaining health and wellness in an aging population PACE goes the extra mile. It's basically long-term care alternative. Where I think it's important, where if UHN and organizations like that get on board, it brings a whole pile of credibility because you've got the University Health Network kind of all coming together. I think the other suggestion I have for you is we need to be okay. You remember there was a time when we talked about the stigma about mental illness and we just didn't talk about it? Now we talk about it. We need to talk about loneliness. We need to talk about isolation.
Yeah.
And it's not just the client, it's the caregiver. The caregiver feels lost. The caregiver feels abandoned. They're burning out. When I'm hearing the stories from our staff in the hospital, it's not the client who's sick, the patient. It's the caregiver who's burnt out. And they're saying, I'm not taking my mom home because I've just been at it too long. And so we need to start talking about, when I go and talk to politicians, I always talk to them about loneliness. And they probably think I'm some kind of, quasi whacked out guy. Just, they think I'm going to talk about stroke. No, I'm talking about loneliness as a social epidemic that's hitting all generations, but in particularly elder citizens. And we need to be okay to talk about it. And I do think NORCs help that, but we need to go the extra mile because that isolation is what's driving people to stop taking care of themselves. You'll see higher rates of self-harm, suicidal ideation, dementia rates, mental health issues with all that population. There's enough data now we can be talking about it. Sorry, I digress, Julie, but I just wanted to, I think what the UHN, what you're doing downtown is fantastic work. And I hope that we're aligned, and I hope we can bring the research community together to bring those two ideas together.
May I just remind you that caregivers aren't always the children. I have two, in the building I live in, there are two partnerships where the 85-year-old caregiver is looking after another 80-year-old partner. And just giving them an afternoon off now and again doesn't need help every day.
And that happens all the time, Julie. You'll be happy to know SSAO has pulled together a provincial NORC organization, and we have a steering committee that's going to be pushing for NORC expansion across the province. So that is happening. As we speak, there'll be a meeting in January, and UHN is on that steering committee, as is Queen's University and their folks who are pushing the OASIS NORC model. So we're pulling it together provincially, and we are pushing for NORC expansion across the province. B. Scott has had her hand up forever. So
good to be partners. Thank you.
You're welcome. B. Scott, go ahead.
Hi, can you hear us?
You need to turn up a little, I think.
Yeah, can you hear us? I'm Rosemary Jacob.
We can't hear you.
Hold on. I got it. We're using a laptop in a theater.
Oh, okay.
Our resident council is here.
All right.
I'm just plugging in some headphones so you can speak 1 second.
Okay.
Yeah, getting there.
Why don't I let Denise go first, and then I'll come back to you. Denise, go first.
Hello, thank you very much. This has been a wonderful presentation. I see there's a question on the chat, and my question kind of is along that line. I was living out in the Durham region for about 10 years. I've been a caregiver for many, many years. When I moved out to the Durham region, I was looking for getting involved with the health system because my dad was in long-term care for a number of years, and that just didn't work out, and I knew it. And then I found SSAO, and I went, oh my God, here we go. This is great. When I was in the Durham area, I did join a hospital committee looking at I was a patient advisor, and I got engaged with the committee, and we were looking at improving palliative care, having quality palliative care. But I was looking for a PACE, a NORC, and how is the word getting out to people in the Durham region that this is happening? Because I would have been on you guys like, a fly on molasses. But now I've moved to Scarborough, and I'm starting a NORC here.
James?
I think first of all, you know, we over the last, we've always had a good relationship with our regional hospital, but we've taken it to the next level over the last few months because we've demonstrated to them what the capacity of the community organizations are. And I think hospital CEOs and hospitals leadership know full well the importance of community, but they're dealing with putting out the fires that they have every single day. And we have to show that we're capable, and we are capable.
Sure.
And so we're building confidence, I think, as a regional system that we can do this together. And I think Lake Ridge Health has been a fantastic partner of ours. I would also suggest to you that, you know, this is the beginning of a process. We need to make this political. We need to talk to our regional councils. We need to talk to our MPPs, because what they're going to tell us is that they spend a lot of money on home care.
Yeah.
Listen, home care ain't all it. Like, I think I was trying to show you that it ain't all it. And it's actually about bringing those social services together, transportation, mental health and wellness supports, day program services. So I think to my perspective is that Trish promised me this, I'm going to hold her to it. She says, James, you keep working on the policy and the program stuff. We'll take care of the political advocacy. I'm like, okay, Trish, you got it, because I want to keep my hands out of that. But I think this, Denise, is a part of a conversation we need to be having in Ontario that says it's time we start doing this. It's our time. It's well past.
Yeah, because I think citizens will just, you know, grab onto it. Again, thank you so very much.
Okay, I'm going to go to B. Scott and Hetty Gadd, who I know you have your hands up, and then Daniela. I just want to mention that I will be meeting with Ray Applebaum, who's with Peel Senior Link, and also with Paul Sharman in Burlington over the next week, because they're putting together a provincial coalition of the willing to push PACE programs across Ontario. So I have a feeling that we may be about, Cecily, where are you? We're about to get recruited, I think, into that. So we will certainly keep people aware of that. And if you join our email list just go to our website, Seniors for Social Action Ontario, join our email list. We send out regular bulletins on things like this. So if we form a provincial coalition of the willing, we will let you know. Okay, B. Scott, you have your hand up.
Can you hear us now? Better?
I can.
Perfect. Rosemary, there you go. Hello. I chair the President
It's not coming through now. I think maybe the microphone's too close.
How are you doing? How are we doing?
That's a bit better.
Okay. My question to you is, for seniors who live in apartment buildings, there is no health care. There are no social other than those they get private. There must be hundreds of
Yeah. I think you're talking about, aren't you, the apartments that are attached to retirement homes?
Only, yes, yeah.
Yes, okay. James,
did you? Under the same roof.
Yeah, you're under the same roof, but some people are in apartments and some people are in other arrangements. So James, did you want to address that one?
Yeah. I want to ask why healthcare provision cannot be mandated in some way.
Yeah. James, did you want to talk about that, or I can, or if you'd like to?
Like, I think both of us, this is actually a real sticky problem. Like, it's not an easy issue at all. It's important to note that residents in retirement homes are still eligible to receive home care supports. What they're not eligible to receive in our area is assisted living services.
Right.
So there's a policy division there. We support retirement home residents with adult day program services, like we can bring them into the program. But as far as being in a seniors building that's attached to a retirement home, you're still eligible to receive ALS. Like, you're still eligible to see assisted living because you're not in the retirement home side. Where I see a potential problem here is that, well, none of our clients pay a fee for assisted living. it's completely free. And that's not the way the model of the retirement home sector works in.
Right.
So it's a Pandora's box. We could be here all day talking about the challenges facing that sector, but it is I think it's an inequity. And I would suggest if you're in a seniors building that's even if attached to a retirement home but not receiving retirement home services, you're eligible to receive home care and you're still eligible to receive assisted living services.
Right. And I think one of the problems, if I can just add, I think one of the problems is that the nonprofits are not funded nearly as well as for-profit long-term care facilities or even Ontario Health at Home. And so what happens is by putting assisted living services into retirement homes with apartments attached, what they're actually doing, in fact, and this is only my opinion, but it's the opinion I've formed over years watching this, is that the assisted living services from the nonprofits who are poorly funded are actually making the retirement home operators richer. And that seems grossly unfair to me when there are so many people who need services. And I understand perfectly, I'm not without sympathy for people living in apartments attached to retirement homes. And as James says, they are eligible. But there are retirement homes and there are retirement homes, and I'm sure you know that. They're all different levels of quality. And you also pay a lot to be there. So, and they are supposed to provide services sometimes that they do not provide. And we hear from a lot of people who are living in retirement homes paying $5,000 or more a month who are not receiving the services that they're supposed to be. So I'll go ahead and say that because we hear from the people who are in that situation.
So what can we do about it?
What can you do about it? What I would do right away is get to your MPP. And just talk about the inequity to your MPP and say that you're asking for assistance. Sometimes what happens is when an MPP's office calls one of these retirement homes, all of a sudden the problem gets fixed. Okay, so that's the best advice I can give you. Hetty, I'm going to move on to Hetty because we've only got a few minutes left. Hetty and then Daniela. Hetty, you're on mute.
Thank you. We met James. I belong to the University Women's Club from Oshawa District, and you were one of our speakers years ago during COVID. And we've always been advocating now for aging in place. And you explained to us how community care works, etc., and that. And I hope your budget improved because when we talked, you had lost a bit of your budget from the government, and I'm hoping that they improved your budget for your services. I live in Bowmanville as well, and we have a very strong older adult association, and we have an older population as well. And there are certain buildings in Bowmanville that have more seniors living than them. Do you know of any movement in Bowmanville towards PACE or any interest?
Well, we cover Bowmanville as well. And Eddie, I have to be upfront with you on this. We're going to target a couple of communities first.
Okay.
So we can demonstrate impact.
Okay.
Because what I would suggest is sometimes the sum is more than the parts.
Okay.
So right now in Clarington, we provide ALS, we provide adult day program, we provide all those services.
Right.
But I need to demonstrate to government the impact of winding those services together for a cohort of individuals. So we're going to pick one or two communities, and then I've met with School Guide Council. I expect I'll be meeting with Pickering as well. But I do need to kind of scale this to show the return on investment for the taxpayer and for the government and for the municipality. So, Eddie, you can have my word on it. We're going to get to Clarington, but this is a bit of a strategy. We'll build it. We'll prove it. We're coming next.
Okay. Thank you.
There we go. And get your council to vote for it. Somebody asked, is there any activity in Hamilton? What I can tell you is there is a ton of activity in Burlington, right next door. Councillor Paul Sharman there. I think it's Karen who asked the question. Karen, contact Councillor Paul Sharman's office and tell him that you want to know, can he give you some direction on how to get it into Hamilton? I think it will start with your council. You probably need to speak to your two counselors and any two counselors on Hamilton Council and start pushing them. Say that you want the Ajax motion, which I can send to everybody, adopted for Hamilton, and then you go the same route. You talk to the Ontario Health Team that governs your area, you start pushing local community-based nonprofit agencies to come to the table, and then you start talking about how you can make it happen. Daniela, I know you've got your hands up, so go ahead.
Trying to unmute. When somebody mentioned UHN Network, I'm also involved with a consultant team at St. Michael's Hospital. I don't know if you guys know, it's a research and training hospital in Toronto. And Dr. Stephen Kwong, we work under Dr. Stephen Kwong, who's world-renowned and a humanist and does a lot of research. And that research that we do is used for systemic and policy change. And I'm just thinking, Trish, you might want to contact him. I'm in a meeting with them next week, and I will forward the two-pager. Okay?
Okay, yeah, that's great. And you know what? Everybody can reach us through seniorsactionontario@gmail.com. That's on our website, right on the front page.
Okay.
So if you want to get in touch with us and hook us up with anybody, then by all means do that and we'll follow up. I'm just letting people know the two-pager will go out to everybody, okay? Because some people are asking. And people are trying to, Joe, you're trying to understand the interdisciplinary PACE team. It's generally led by an organization with the support of local politicians, and in our case, with Seniors for Social Action members as well. So that's generally how that would happen. I think James has answered your question as well, so I'm just going to move on there. We have one more person who had her hand up, I think. Have I missed anybody?
Sorry, I just forgot to say also, I'm seeing my MPP actually at a church function, and I will speak to her about this. Jill Andrews in Toronto. She is quite amazing, and thank you so much for this, guys. And I'll shut up now.
Okay, I just want to say something here, and it's going to sound a little bit political, but I'm sorry, I have to be truthful. We have tried to get the provincial NDP on board on alternatives to institutions, and they will not come on board. We believe that the reason is that the Ontario Health Coalition, which represents the unions in the long-term care homes, is trying to protect the jobs in those homes. And if we're successful in building the alternatives, it will put pressure on the long-term care homes. So we're having a little difficulty, have had for 2 years now. We've tried to work with the OHC and we can't get anywhere. And the NDP is listening to the OHC. They're not listening to us. We have tried. Our members who have been New Democrats for life have tried with Catherine Fife, Jennifer French, Lise Vogio up in Sudbury, everybody. And we're getting absolutely nowhere. So those of you who have some schlep with the NDP, please put some heat on them that they need to start getting on board with these alternatives. So that would be a great help to us. Same thing with those of you who are liberals. The Liberals have been slow to roll out policies on this. And so, you know what? Get to your Liberal MPPs and if you're working for the party, please get to them and put some heat on them as well, because we need all of the opposition parties on board on this. The Ford government's been very slow, but I will tell you that they did actually fund for $4.5 million a PACE program in Kenora. So that's hopefully the breakthrough. Maybe we can get them to fund some more of those. That was the Ministry of Long-Term Care, I think, that partnered with a community group up in Kenora that pushed them. And they got a PACE program funded up there. James, did you have any comments that you wanted to wind up with?
Just two comments. I mean, I'm all about giving people choice about how they choose to age in their community, and I just want to offer them a different choice. I believe we can do better everywhere, not just in home and community. I believe we should be doing better in long-term care, but I want people to have the choice. I also just want to again express my gratitude for all of you taking time on a Thursday evening. It used to be Seinfeld night. I don't know what happens on Thursdays on TV anymore. But I just want to appreciate the support you've given us by participating in this. I think the more champions we have asking questions about what is PACE and how can it work here, it starts to raise the conversation. And by raising that conversation, people become curious. And by
Yeah.
becoming curious, you learn. And I would just suggest that Ontario, given the fact we have a single healthcare insurer, it makes no sense to me why we can't do this here.
Exactly.
Right.
Yeah.
It's about the silos we live in, and we need to break down those silos. So
Yeah.
thank you, Joe. Thank you, Trish. Thank you, everyone who's helped me in this conversation. And thank you all for joining with me tonight.
Okay, thank you, James. This was a very informative presentation, and you're doing good work, you and your staff and your board every single day. And we've been so appreciative of you working with us to get PACE rolling here in Durham Region and especially here in Ajax. Ajax has often been a little bit forgotten in Durham Region, but not now, which is really great, and that's largely thanks to you. I'm seeing people saying thank you to you. Somebody asked about movers and shakers on Oshawa Council. You know what? Start with any of your municipal councilors and just speak to them, because I think many of them would like to see something happen, especially for older people. So just, choose whoever your local municipal councilors are at CFUW in Oshawa, talk to them. Community agency readiness, Helen. I think James and Peel Senior Link and Chats, I think some of the Chats people have been here today, and Sprint, Neighborhood Link. I think a lot of the community agencies want to do this and they want to get going on it. They need the community support, and we have to provide that. That's up to us to get to them, to talk to the CEOs, to say we want to support you. How can we do that? And to try to get that going. So yes, it would impact provincial rollout, and it already is. That's why James is talking to some key people, and hopefully we will be able to impact community rollout. So everybody's saying thank you, James, and I am too. So thank you for a wonderful presentation, and have a great night, everybody. Denise is waving, we're waving, so have a great night. Take care, everyone.